Thank you very much, Bruce. Yo quería hacerle una pregunta a Francisco Arlanich, y es que recientemente, revisando la literatura, he visto algunas publicaciones donde se aprecia que el porcentaje de amebas de vida libre que producen infección en el ojo humano, puesto que clínicamente son indistinguibles, el porcentaje de gérmenes que no eran Acanthamoeba era superior a los que eran Acanthamoeba. O sea, ¿tú crees que puede haber un cambio de tal manera que el género Acanthamoeba se está reduciendo en su incidencia en el ojo y otros géneros están ocupando esa parcela?
Yo no he leído, vamos, no tengo conocimiento de eso. Yo sé que han aparecido otro tipo de amebas coasociadas con la Acanthamoeba, pero creo que la Acanthamoeba sigue siendo el germen más frecuente. Lo que pasa es que ya no se llaman, o por lo menos los parasitólogos no les gusta llamarles Castellani o Culversoni, como le llamamos antes, sino lo genotipan. Entonces sí que yo creo que todos van a entrar en el genotipo del T1 al T18. Yo no sé si luego eso equivalía a otro tipo de nombres que le daban anteriormente, pero por mi experiencia, que tenemos bastante, y sobre todo trabajamos con el grupo de parasitología del grupo de Canarias, yo no soy... O sea, lo que nos hemos encontrado es balcancias, por ejemplo, una anagleria en un caso, pero son casos anecdóticos, no creo que la mayoría. No tengo yo esa impresión.
¿Crees que sería interesante valorar la evolución clínica y la respuesta al tratamiento según genotipos?
Sí, nosotros tenemos un estudio precisamente publicado, no me acuerdo si en córnea, y lo que pasa que, claro, el T4 es 85%, 90%, pero teníamos 3 casos de genotipos T3 y uno T11, y luego 10 o 11 casos de T4, y los no T4 tenían peor pronóstico que los T3, y con un hallazgo... Perdón, los no T4 tenían peor pronóstico que los T4 y no eran pacientes que se hubieran descubierto ni antes ni después. O sea, el grupo clínico era muy parecido, las características clínicas. Pero bueno, es un hallazgo muy casual, de muy pocos casos. Deberíamos estudiarlo porque tienen que tener diferencias, seguro.
Frank Larkin, also from Moorfields. Could I just add to what Bruce and Francisco have said? Bruce said, if in doubt, treat as Acanthamoeba, and I would add that you must suspect possible Acanthamoeba in any stromal keratitis patient if they look like HSV, and especially if the patient wears contact lenses. So in the UK, we regard it as clinical negligence. If you do not take a history of contact lens wear in a patient and manage a patient as stromal herpes, you must refer the patient for Acanthamoeba if you cannot do the investigation yourself. So that's just a practice point to add to the very thorough advice given by both of the speakers.
Yeah. Thank you, Frank. I completely agree. Yo lo digo a todos los residentes, es decir, un paciente con lentes de contacto y herpes puede ser un herpes, pero no podemos presumir que es eso, porque lo más frecuente es que no sea un herpes, que sea una ameba y que se nos haya pasado.
Sí. Aquí una pregunta acerca del tratamiento para el doctor Bruce Allan. Quería preguntarle si tiene algún lugar o tiene alguna experiencia con tratamiento con povidona iodada en ameba. Y otra pregunta, hace unos años el grupo de Canarias publicó la efectividad de tratamiento con estatinas que inhiben el ergosterol y que era muy efectivo en amebas. Quería saber si tenía alguna experiencia al respecto.
Bueno, los dos puntos son nuevos para mí. No tengo experiencia de povidón y estatinas tampoco, pero imagino que hay muchos tratamientos diferentes que ya no hemos tratado.
Yo le he puesto vía oral, la estatina, desde ese artículo he puesto vía oral y no he visto diferencias. Los que van bien, los que van mal, por vía oral.
Bueno, Javier me ha tomado ya la pregunta, iba a hacer la misma, pero the question is about povidone and also natamycin, because of course there's this famous paper by the Japanese in vitro showing that these were the best drugs killing everything.
So mitomycin is good for everything then, isn't it?
No mitomycin. Povidone and natamycin. But nobody's trying natamycin.
Yeah. I think that I might refer this question back to Frank, actually, or Steve, but my understanding is that the antifungals the organisms are sensitive to antifungals in the trophozoite phase, but not in the encysted phase. And this is the difficult area for acanthamoeba. So what you see in a dish, it needs to translate to clinical reality and practical use. And we know that the biguanides work, but I'm sure there are other possibilities too.
Yeah, apparently in vitro, there was a response also to the cyst to natamycin in vitro. But
Okay, I stand corrected.
¿Más preguntas?
Sí.
Sí.
Bruce, what do you think about epithelial debridement? It's a therapeutic maneuver that
Yeah.
we should do in any case. In
Yeah,
each case.
I am pleased you asked me the question.
Yeah.
I think, and this is again is not in the textbooks, not in the journals, but it's almost, for me, pathognomonic if the epithelium comes off in a sheet in an acanthamoeba case. A typical early acanthamoeba case, all you will see is that actually Francisco showed us some really nice slides of the epithelial phase. And you have this frosted glass appearance to the epithelium that is quite characteristic in acanthamoeba. And when you do an epithelial biopsy, the epithelium comes off in a sheet. It's very loosely attached. So I think it's a diagnostic clue that many of us are perhaps not aware of. But more importantly, it's therapeutic. It's therapeutic as well as diagnostic. I think Steve made a similar point about fungal infection too, is that drug penetration is very important when you're trying to treat these difficult organisms. And removing the epithelium is helpful in terms of helping drug penetration. So in a fungal infection, we actually bring the patients back to debride to remove the epithelium every 1-2 days. And certainly at the beginning of the intensive treatment phase in acanthamoeba, before the organisms have encysted, I think it's a very good idea to debride the epithelium, both to remove the organisms and to help drug penetration.
Also for epithelial herpes, it's all a therapeutic tool that we have.
Possibly.
Yo, dos preguntas de cirugía. Una, nunca tienes prisa en una ameba, pero ¿cuándo tomas la decisión de decir, ya no hay más, voy a por una penetrante como terapéutica, no para rehabilitación visual, sino como terapéutica? ¿Y qué hueco qué hueco tiene la DALC en la ameba?
¿Qué ha dicho? ¿Qué hueco tiene la DALC?
Yeah, I can try and answer in English if that's okay, David. We don't so often see the need for corneal grafting now, but still often enough. And there are two different ways of thinking. There are some groups that are publishing on doing surgery earlier, but the recommendation, certainly from John Dart, who has probably more experience than any of us in this area, is to wait for 6 or 8 months of medical treatment before considering surgery. Then do you do a penetrating graft or do you do a lamellar graft? I don't know the answer to that. There have been recent publications. Singapore, for example, they have shown some good results from lamellar grafting. And one piece of advice from John, I can remember some difficult cases that I've shared with him on this particular area when you have had to do a graft and you get a recurrence in the graft. Often the organisms, his theory is that the organisms come back into the graft, and so the first graft fails and then the second graft is successful. So when I have been to him with a bad situation after a first graft going wrong, his advice has been don't panic, do a second graft. And on the 2 or 3 occasions when I've had to do that, it's been successful, but that has been a penetrating graft.
¿Alguna pregunta más en la sala? También.
I have one question. In your opinion, do you think that PHMB is more or less toxic for the eye surface than the chlorhexidine? Which one is more or less toxic?
I can't give you a good answer because we always use PHMB as primary treatment. And then if we are going on to secondary treatment in a case that's not responding, it's either fortified PHMB or fortified chlorhexidine, in other words, a higher percentage. And when the percentage for the, and both are toxic, by the way, when the percentage for the ODAC trial was, the figure of 0.08 was decided on based on a balance between toxicity and increased strength. But I don't have a clear answer for you there.
Hola, era una cuestión sobre las coinfección o sobreinfección bacteriana. En los estudios que hicieron los microbiólogos en la Universidad de Zaragoza consideraban que muchos de los quistes de ameba tenían en su interior partes de bacterias, incluso bacterias enteras, y lo que nos indicaban es que era muy importante la protección antibiótica coadyuvante porque la pseudomonas se había encontrado incluso íntegra y con actividad. Entonces, en vez de una sobreinfección, deberíamos de considerar que podía existir una coinfección con las amebas, por ser capaces de sobrevivir los gérmenes en el interior de los quistes. Era por si de verdad considera que es importante el tratamiento antibiótico, además del tratamiento para el protozoo.
Bueno, so,
understood?
Yeah, I think so. Creo que he entendido, sí. So, in a typical early case of acanthamoeba, it looks like acanthamoeba and nothing else. You can be fairly confident using biguanides and hexamidine, as we do. These, remember, are broad-spectrum antiseptics. And so I don't think you need to introduce antibiotic cover as well. But if there are atypical signs, or if you have a positive culture or gram stain suggesting co-infection, then sure, co-treat with intensive antibiotics. The point being that nothing happens fast in acanthamoeba, whereas in Pseudomonas, co-infecting with acanthamoeba, everything can happen very fast. So then you definitely need to use antibiotics as well. So in the end, it is a question of clinical judgment. But for me, I think that I have a sense of when we have a classic acanthamoeba case. It looks like acanthamoeba and nothing else. But I don't know how helpful that response really is, though.
Ángel.
¿Es prudente hacer una cirugía refractiva corneal después de una infección de acanthamoeba? Y si lo es, ¿cuándo se puede hacer o con qué criterio?
Okay, I understood the first part of the question. Is it safe to do refractive surgery after acanthamoeba? But
When?
Okay.
If it is, when it is?
Okay, so this answer generalizes to all visual rehabilitation in post-infective scarring. Okay, the first point is that many contact lens wearers do not want to go back to contact lens wear and so are attracted to doing laser surgery. The most important piece of advice, I think, is wait at least 6 months after the active phase of the infection to allow the cornea to heal, to remodel, and to stabilize. You can get quite a lot of visual improvement in that phase. So the first thing to do is nothing. You have to ask the patient to be patient, if you like. But after I allow 6 months, but you can make a figure up of your own. But I think between 6 months and a year is about right to allow remodeling and stabilization. Then I think you are perfectly safe. And we were discussing this at a conference just last weekend when John, in fact, was speaking on acanthamoeba and how frequently recurrence occurs after you have got the eye healed and stable after the termination phase. And the answer appears to be that recurrence is very unusual. So I think you are safe.
Yo he operado a algún paciente y siempre y cuando no tienes cicatriz residual, el resultado es igual que cualquier otro paciente, ¿eh? No hay problema en operarlos.
Bien, pues si no hay ninguna pregunta más, estamos en tiempo. Vamos a dar paso ya al siguiente bloque sobre queratitis víricas. Gracias a todos los participantes.